8:33, so maybe we will start. Good morning, everyone. Welcome to Pediatric Grand Rounds. This is the last Grand Rounds before the summer break. And so we have a special treat with our guest speaker today. Dr. Jabour is away, and so I'm pleased to be pinch hitting for her as your host and delighted to introduce today's speaker. Before we get to the introduction, we'll begin with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. This morning's speaker is Dr. Nicole Racine, who is a registered psychologist and assistant professor at the University of Ottawa. She is the CHEO Research Institute and University of Ottawa Chair in Child and Youth Mental Health and Director at the Early Lab at the University of Ottawa. Her novel research program examines the impact of early adversity in early childhood and identifies prevention and intervention approaches that promote resilience for children exposed to maltreatment. She is the recipient of early career awards from the Canadian Psychological Association and the Mental Health and Prevention Journal for her distinguished contributions to mental health research. Even early in her career, she's already published over 85 papers in high-impact journals in the field of mental health and trauma. Her work has been included in key policy documents on mental health by the Royal Society of Canada and has informed bills put forward to the House of Commons. Her work has also been cited in key position papers on child mental health, including reports from the U.S. Surgeon General's Advisory, UNESCO, UNICEF, and the World Bank. It is clear she is deeply committed to sharing knowledge that will improve policies and program implementation for children exposed to trauma, and we're very fortunate to have her at CHEO. Today, the title of Nicole's presentation is Risk and Resilience in the Face of Childhood Adversity, Connecting Science and Practice Through Community Partnerships. Nicole.
Great. Thank you, Jason, and thanks for the warm introduction and giving me the opportunity to close out the rounds before the summer. So I'm really, really delighted to be here. So as Jason mentioned, I am the new CHEO Chair in Child and Youth Mental Health at the Research Institute and at the University of Ottawa. And I actually just moved to Ottawa about a year ago and started my position at the RI in November of 2022. So it's just been over 6 months since I've arrived. And I've had the pleasure, I think, of meeting many of you. But for those of you who don't know me, I am a clinical psychologist by training. I did my PhD at York University in Toronto and trained clinically at SickKids and at CAMH. In the middle there, that's my proud supervisor, Rebecca Pillay-Riddell. A lot of my PhD work focused on parent-child interactions and early childhood mental health in a pain context. I moved out to Alberta, to Calgary, to the Alberta Children's Hospital to do my residency in clinical and pediatric child psychology, and then stayed for a postdoc with Sherry Madigan at the University of Calgary. And here on the right, you see photos of life since being in Ottawa. Those are the beautiful fall colors outside of my office at U Ottawa and Vanier, sunrise along the canal, and my 4-year-old doing some cross-country skiing in Gatineau Park this past winter. So in addition to the wonderful researchers, trainees, mentors, and students who I've had the chance to meet at the CHEO RI, it's really been wonderful to be in Ottawa. So just to orient you a little bit about what I'll share with you today, I'm going to talk a little bit about why I study childhood adversity and why I think it's important. And given that this is a pediatrics Grand Rounds, I don't think I'll be convincing anyone of anything they don't already know. I'll shift to talking about how childhood adversity is transmitted across generations, focus on risk and protective factors for mental health for kids who've been exposed to adversity, specifically high levels of maltreatment. And then I'm excited to share with you some community-based approaches to mental health treatment that I have been involved in and that we're currently developing as future directions. So the true character of society is revealed in how it treats its children. And for many of you, this won't be a new stat, but in Canada, we could be doing better in this regard. When we look at other wealthy, high-income nations, we rank 31st out of 38 with regards to children's mental health and happiness. And there continues to be significant work to be done to support children and families in Canada. And unfortunately, this situation has worsened during the pandemic. This news article published in the CBC actually during the pandemic, or in 2023, quotes that at CHEO, 100% of capacity in terms of mental health beds was achieved. And so we are continuing to see a big children's mental health crisis. And there was a crisis before because we had largely unmet needs for children's mental health. But I think the pandemic and the aftermath of that has really hammered that home. And certainly our research has supported this, looking internationally at the prevalence rates increases to about 25% of kids meeting cutoff for clinical depression and 1 in 5 experiencing clinical anxiety. Now, this was early in the pandemic, but we've since done work that summarizes basically that we've also seen increases, especially in depression, especially for girls, with regards to pre and post-pandemic estimates. So there are a lot of reasons why children and youth in Canada might be struggling. And a recent report by Children's First Canada, and this is a great organization who puts out an annual report every year, looking at the top 10 threats to Canadian children. And as you can see here, these are significant threats. And one in particular that has been a focus of my work over the last 10 years has been number 4, child abuse, and specifically focusing on maltreatment. So that includes physical, sexual, and emotional abuse, as well as neglect, emotional and physical neglect, and being exposed to household challenges. So things like having a parent with a significant substance use issue, parent with a severe mental health problem, or exposure to family violence. And we know that many of these experiences, they cluster together, so they co-occur. And they also, it's important to note that there are equity stratifiers like income, family education, age, race, ethnicity that come to bear on the likelihood that kids may experience some of these adversities. So for example, here you see the tree that has some of the adversities listed in it that I mentioned before, but the roots of the tree are actually in soil that have lots of social inequalities. So things like poverty, violence, poor water and air quality, substandard schools. And so this would be more broadly considering the types of adversities that children are exposed to. And now more recently, we're turning our attention more and more to the climate crisis and how children who have other barriers and inequalities that exist for them are also more likely to be exposed to the negative impacts of climate change. So we know childhood adversity is an intersectional experience. So by this, I mean that as a result of historical trauma, systemic injustice, and discriminatory policies, not all children are equally likely to be exposed to high levels of adversity. So why does this matter? Why has this become the focus of my research? And it's because there's now extensive evidence demonstrating that exposure to adversity in childhood is associated with poor health and mental health across the life course, and even premature death. Childhood adversity accounts for up to 32% of attributable risk for adult psychiatric disorders, which makes it one of the most preventable causes of psychopathology. So it's really critical for us to understand what factors exacerbate these exposures, how we can prevent it, and also what intervention approaches we might be able to use when children have had these exposures. Importantly, it also makes good financial sense. I love this term, pedionomics, the idea thinking about the earlier we invest. So in early childhoods, I'll present you some evidence in a few minutes about, maybe pregnancy or even prior to that might be a good idea. But a 10% reduction in early adversity would result in cost savings of $56 billion in North America every year. And so it's also good economic policy for us to invest in child and youth mental health. So burning question in my program has been, why do some children flourish while others struggle in the face of significant adversity? And if we can understand how we can help all children flourish despite these experiences, because number one would be to prevent them, and that's challenging to do. But how do we help all kids thrive? And I've used the word resilience, and I know that's a term that has come under fire a little bit with regards to, especially during the pandemic and also in different contexts around when people think about it as an individual trait, this idea that, perhaps if someone just tried a little harder, if someone just picked themselves up by their bootstraps, they could be resilient. And resilient science itself and scholars in resilient science have really talked about resilience as a system level adaptation and better than expected outcomes in the face of significant adversity. And so without considering factors that occur at all levels of a social ecology and what supports actually exist for an individual, we're not considering resilience as it's defined. So resilience is not an individual trait, rather it's the capacity of systems to adapt and to support individuals in the face of adversity. So before I dive into work, I want to share a little bit about how we can think about childhood adversity, and this will guide some of the key studies that I share with you from some of my work. So we know we can't think about kids' exposure to adversity without thinking about the broader social ecology. So I just mentioned this. If we're going to think about them adapting, then we need to think about the individual child, we need to think about their families, we need to think about their community and the broader context and neighborhood that they're situated in. We also need to think about the fact that children don't just show up in the world, that they were infants, that they have parents, that at some point those parents also were children, and that there are influences and potential mechanisms that could extend far beyond the child themselves to have an impact on how adversity is experienced. And then lastly, that there are factors that occur for the child that can either increase the likelihood of a poor outcome or mitigate against it. And so that's some of what I'll share with you next. So how is childhood adversity transmitted across generations? So over the last 20 years, there's been a lot of research on the negative influence of adversity on health and mental health, starting with an initial study in 1998, really demonstrating increased odds of poor health and mental health outcomes in adulthood for individuals who'd experienced abuse and household challenges when they were young themselves. And there was also a lot of biological research that was happening, looking at what the impact of adversity was on fetal development. So at the biophysical level and the biological level, looking at the impact of that on the fetal brain, as well as on the placenta. And there continues to be a lot of really interesting work in this area related to the developmental origins of health and disease. What had been less studied was, what does this look like in the postnatal environment? And what are some of the psychosocial mechanisms that might actually be contributing to how childhood maltreatment is transmitted? So to answer this question, I've had the great fortune of collaborating with Dr. Suzanne Tuff, who's the lead of the All Our Family study in Calgary, Alberta. She's an epidemiologist, and in 2008, began a prospective pregnancy cohort where they've actually followed women twice in pregnancy in the postpartum at 2, 6, and 12 months, when the kids were 2, 3, 5, and 8 years of age. We followed them 3 times during COVID, and we're actually just doing the data collection now of the youth who are now 13 to 14 years of age. So this is a really rich data set and allows us to answer a lot of interesting questions about how the early years may bear on both child development, but also children's mental health as kids age. And interestingly now, we're able to ask the youth themselves. So it's actually become an intergenerational cohort. The sample itself is of just over 3,000 women. And here I'll report on 2,000 of them, mothers who reported on their own childhood adversity. And the sample it's a community-based sample, and it's representative of the demographics of Calgary. So it's an urban and highly educated, and it's not an at-risk sample. So these are women who would be considered who would be considered at the population level in Calgary. So in terms of our methods for this study, so mothers retrospectively reported on their exposures to adversity in their own childhoods. And interestingly, we've actually had mothers report on this twice and found that the concordance is high. And actually, as mothers stayed in the study, they reported more to us than they had prior. So this is interesting around trust and also retrospective reporting of maltreatment. During pregnancy and at birth, we obtained a measure of psychosocial risk that included maternal mental health, social support, mom's education, and income. We had a measure of maternal health risk that came from linkage to their health record, as well as infant health risk at birth. So these would have been things like a cumulative score, including low birth weight, prematurity, an NICU stay, or having a congenital abnormality. At 4 months, again, we had a measure of psychosocial risk related to mental health, and as well as a self-report of hostile maternal parenting behavior, which would include things like yelling at a child or losing their temper. And at 12 months, mothers completed the Ages and Stages questionnaire, which is a really common measure of children's developmental milestones that includes subscales like communication, problem solving, social skills, and motor skills. So I'll walk you through this model, but the main takeaway, so this is a path analysis, is that we were looking to find indirect pathways. So when we looked at the direct association between mom's ACEs and infant's development without any of the extra lines, there is a small but significant association between maternal exposure to adversity and infants' development outcomes. So moms who had more experiences of adversity had children with lower developmental outcomes. But what we also found was that moms who had higher levels of ACEs were more likely to have mental health challenges during their pregnancy, which was associated with poor maternal parenting behavior and subsequently was associated with poor infant development outcomes. And on the biological end of things, moms who had higher ACEs were more likely to have pregnancy risks, health risks, which was associated with increased likelihood of infant health risks and was subsequently associated with poor infant development outcomes. And so after we had accounted for these two intermediary pathways, there was no longer a direct effect between mom's childhood adversity and poor child development outcomes, which tells us that it's really important to be thinking about what actually are the mechanisms along the pathway and helps us highlight where we actually might be able to intervene. It's also important to know that equity stratifiers in pregnancy, like social support and mental health, were associated with transmission and were on the pathway, and that parenting behavior may actually be an important intervention target when we're thinking about how we might mitigate poor developmental outcomes for infants. Interestingly, in a subsequent follow-up study where we were looking at moms' health risk scores in pregnancy, we found that for those who had high social support in pregnancy, they actually had reduced associations between ACEs and antepartum risk. So basically showing us that social support in pregnancy can be an important buffer. So what we learned was that the prenatal and postnatal environments are opportunities for early intervention, that we may want to consider thinking about what the impact is of maternal exposure to adversity and how we might talk about this in the prenatal care setting, as well as early identification for parenting supports. And here on the left is a graph taken from James Heckman, who's a Nobel laureate in economics. And when this graph was first made, it was really focused on the early years and investment in the early years in the 0 to 3 and the return on investment, that for every dollar that you spend in the early years, it's worth 13 later. And I'd say about 3 or 4 years ago, they actually added that brown bar on the far, far left, which is the prenatal, I think really indicating that there's a window of opportunity in pregnancy and the postpartum for change. And we've subsequently done a meta-analysis on intergenerational transmission from not just mom, but parent adverse childhood experiences to child mental health difficulties. And in terms of direct effects, we see an effect size of about 0.2 across 87 effect sizes coming from studies. And so what we know is this is a small to moderate effect, but what's even more important is for future directions of research to focus more on mechanisms and where we might in fact be able to intervene. So related to that, I think what this made me think about, at least in my own research, is this idea of the importance of going upstream. And as a clinician, having worked in child abuse services with children who have been maltreated, most of whom I see maybe around the time they're between 7 and 10 years of age, a lot of life has already happened by then. And I think the earlier that we can intervene, there are some real opportunities there. So some of what we did based on the research that we had found was in partnership with a maternity clinic in Calgary. It was a low-risk maternity clinic of about 40 physicians who were delivering the majority of babies in the northwest quadrant of Calgary. They were actually implementing a trauma-informed care initiative and approached us about evaluating it and understanding what the impact might be. And so we actually did a pre-post implementation study where we did a retrospective file review of medical records, looking at both maternal health risks and also infant health outcomes following the implementation. So they had really done a lot of work to train their entire staff to be trauma-informed and trauma-aware They had implemented conversations with mothers about early childhood adversity, the impact of that, referring mothers who had mental health needs for additional supports, and encouraging women to have conversations with their partner about these things, as well as whether or not these things continue to impact them now. What we did find was, after the implementation of this approach, a small reduction in infant health risks. Now, this isn't an RCT, and it's not a perfect design, but I think the most important findings that actually came from this work were the qualitative ones, with physicians who shared about how initially they had been really afraid to have these conversations with their patients. They felt like it was opening up Pandora's box, but in fact, these were real opportunities, and often didn't take any longer than they normally would have planned for a visit. Also at a greater population level, so to try to provide parents with information about improving the relationship between them and their infant, we are currently undertaking, this is a randomized waitlist control where with Halton region and Peel region, where we're looking at implementing an online parenting program that's available to caregivers, so that they can improve, especially in the first years postpartum, their relationship with their child. So we'll be evaluating whether or not this method of delivery, in particular online, COVID disrupted so many things about how families receive service. And many families have actually said they don't intend to return to in-person service. Now we know for some families that's really necessary, but for others, we're interested in whether accessing a program related to parenting can lead to improvements. And then lastly, of course, for families who are really the most marginalized and have experienced the highest levels of adversity, simply an online module on parenting practices isn't sufficient. And so in partnership with the CHEO Research Institute and other organizations across the country and institutions across the country, we're leading the evaluation of an early intervention program for mothers who are substance involved and their young children, with the hopes of reducing the adverse childhood experiences that their children themselves experience. Mothers in these types of situations and programs, research over the last 30 years have shown that 100% of them have been exposed to childhood adversities, and many of them, some of the most severe and significant that you could imagine. So we'll be running a study evaluating Breaking the Cycle, which is a program for substance involved moms, comparing it to another program that doesn't focus on the parent-child relationship and infant mental health, and then implementing that program at other sites across Canada. So next, I'll share a little bit with you about what we've learned with regards to risk and protective factors for mental health after exposure to childhood adversity, specifically maltreatment. So I'll share some work with you that's been conducted in collaboration with the Luna Child Advocacy Center in Calgary. For those who aren't familiar with the Child Advocacy Center model, these are partnership organizations that bring together children's mental health, children's health, the judicial system, child welfare, as well as police. And so it's really designed to be a one-stop shop for families when a child has been exposed to maltreatment. The idea being it's a trauma-informed approach in that children don't have to tell their story twice. They tell their story once, and then information is shared across all the partners. And this is a place that's meant to be supportive and healing. At this point, there are about 30 child advocacy centers that are either in development or that have been formed across Canada. So in this study, we were looking at the files of children who had been referred to the Child Advocacy Center. And as you can imagine, these are really detailed files, a lot of important information that we're able to extract. And this is also was an initial trauma-informed way of doing our research with this partner, because we didn't have to interview families or give them questionnaires or ask them questions about things they had already answered or provided as part of their clinical service. We have since moved on to doing formal data collection with families. And again, we link the research data that we're collecting that's unique to their clinical files and to data that's already in their health record, so that we don't have to ask them twice about information that they have already reported. So in this particular study, we looked at the number of adverse childhood experiences that children had been exposed to, including the 10 that you see here. And then we also looked at using the Child and Youth Resilience Measure developed by Michael Unger, whether or not children had the following protective factors present. So at the individual level, things like personal skills, so these would be individual coping strategies that had been reported, peer support, so support from their friends, whether or not the child had good social skills, whether they received physical care from their caregiver, so whether their physical needs were adequately met, if they had emotional support from a primary caregiver, and then in the community context, whether or not the child had adults or people who supported them with regards to spiritual growth within the education system, or perhaps from a cultural perspective. We also looked at children's trauma symptoms, and this was at the outset, so prior to them receiving any kind of treatment or intervention for mental health related supports. And so we looked at 15 symptoms that are associated with the diagnosis of post-traumatic stress disorder in children and youth. So for this particular sample, children on average were 11 years of age, but there was a range, and most of the children were female. This isn't uncommon, as many CACs tend to have a higher proportion of sexual abuse than they do of other types of maltreatment, because of the police involvement that typically occurs with these types of reports. And notably, the majority of mothers of kids who were seen at the CAC themselves reported having an abuse history. What we found is in line with what I was telling you about before, which is that these experiences are not mutually exclusive and tend to be cumulative. So most children had experienced many of the adversities that we're talking about. And the rates of anxiety, depressive symptoms, nightmares, and suicidal thoughts were quite elevated. In fact, a cutoff, especially with the ACEs measure, the 10 ACEs measure, 4 or more, kind of is considered a tipping point around when we see some of the most problematic outcomes. And we found that 62% of kids in this sample had 4 or more of those adverse childhood experiences. The trauma symptoms, the types really varied by age. In younger kids, this looking more like regulation difficulties. In older kids, it looking more like externalizing and substance use, and girls being much more likely to experience physical and sexual abuse than boys in the sample. When we looked at the presence of protective factors, interestingly, what we found was that most of the time, almost more than 80% of kids had some of these protective factors present for them. And so the kids who we're really worried about are actually that 20% who don't. And what our research showed was that protective factors mitigated or dampened the association between exposure to adversity and children's trauma symptoms. So kids who had more of these protective factors already in place were less likely to develop symptoms of PTSD. We've also turned our attention to focus on how kids do in treatment as part of this program. What we know is actually that about 40% of kids who engage and families who engage in therapy for child maltreatment drop out, so they don't actually complete the recommended treatment. This is a big problem because we know that trauma treatments being effective are actually reliant on families engaging in them and participating in them, and that kids who drop out of treatment are at risk of elevated trauma symptoms, having other mental health symptoms that are in the clinical range, and increased functional impairment. So we've been really interested in this and trying to understand what predicts treatment dropout. And when we looked at a number of different factors, what we found was actually child age, so children who were older, as well as protective factors, so children who had less supports in their families were more likely to drop out of treatment, even after including the number of childhood adversities or severity of trauma symptoms in our models. And so what this told us actually was considering or having a sense of what kind of supports families have before they even start treatment, potentially bolstering some of those may be really important for kids' success. And that ultimately having some of these protective factors present are associated with treatment, could be potentially associated with treatment equities, making sure that all kids have equal access or equal opportunity to be successful in treatment itself. So what did we learn from this work? Well, that polyvictimization and cumulative risk are the rule, not the exception. Children exposed to complex trauma have varied presenting concerns and profiles, and that protective factors can really play an important role in mitigating both the development of trauma symptoms, but also premature dropout from treatment. And because this work was conducted so closely with the clinical team in Calgary, they've actually implemented and changed a lot of things about their service provision based on the research that we've done. So, for example, they've put a lot more emphasis on complex trauma and the assessment of complex trauma. They're also now measuring protective factors at the outset of treatment. And there's a much greater focus on parent engagement and providing supports to parents when kids are engaging in the therapeutic process. So shifting a little bit to tell you about some of the community-based approaches to mental health treatment for kids who have been exposed to adversity that our research group is working on, and future directions that we're excited about. So we know it takes a long time for work that is done in the academic silo to make it into practice. And I think, a common number that's thrown out there is this idea of 17 years. And when you're a clinician and you work in clinical settings, you become acutely aware that that's really too long, and that it's more optimal to bridge those gaps and for implementation to happen more rapidly. That being said, doing this kind of research really requires researchers to go beyond boundaries and comfort zones of sometimes of their areas of expertise, and requires stepping outside of the lab setting or of studies that sometimes offer a lot of control. And they also involve partnering with other individuals. And I think this is something that's so rich and happening at the RI with regards to community collaborations with patients and families through PFAC, stakeholder engagement, as well as collaboration with industry partners. So I'll just share with you a couple of examples of how we're trying to narrow the research to practice gap, where that's going, and then maybe hopefully in a year or two, I can come back and share with you findings from those projects. So the first is actually one in collaboration with the Luna Center that I was telling you about, where we know that kids were, first of all, that there are long waiting lists for accessing trauma treatment. Second of all, that there are engagement issues with regards to how do we get, once families are in the door and they're ready to start treatment, how do we ensure that they stay, right? That we don't have a 40% dropout. And one thing we thought a lot about during the pandemic was that when we have families who are waiting on a wait list, there's an opportunity there to provide something or to engage them in some way that bridges the gap between having had an exposure of maltreatment. So for example, a child who's been sexually abused, and them actually getting the treatment that they need. So with our clinician partners, we've developed online modules for caregivers about how to support their child with trauma, and we're calling this the COPE project. We've co-created the content with clinicians. There's video library that provides both psychoeducation and also coping tips. And we're in the process right now of doing a mini pilot. Does this help people? Does it actually work in reducing trauma symptoms, both for kids, but also parent distress and stress from pre to post? And then we'll move on to a larger implementation trial at 8 child advocacy centers across the country. So this has been such an interdisciplinary approach and project. Even actually members of our team who are the web designers and builders have been so integral to this. And so we're excited for this to be a resource that can be shared not only with CACs, but more broadly. Another example since coming to CHEO has been a collaboration with the Vanier Social Pediatrics Hub. So here's the co-PI on the project, Dr. Sue Bennett, who leads the clinical intervention at the Vanier Social Pediatrics Hub. And a fun project that we're getting to do this summer is actually 32 kids who present with behavioral and emotional difficulties as referred by their community or school, and also live in an underserved part of our city and have been exposed to significant adversity. We'll actually attend a summer camp at the Museum of Nature, and we'll have the opportunity to evaluate that using both quantitative and qualitative methods. We actually went and visited the Museum of Nature yesterday. Here we are in that picture there. I think we're still for that picture because we're being swarmed by mosquitoes for part of it, but we're really excited about this project, excited to have CHEO's support in it and to move forward. And then lastly, some work that I've been doing recently, and this is since being at CHEO and will be housed at CHEO, is related to identifying research priorities for youth who have been exposed to maltreatment, particularly using an equity-based lens, engaging youth as part of our steering committee, and then being able to identify these research priorities that then can be used to guide research that's actually important to families, important to youth, and important to clinicians. And so this is a study that we're moving forward with this year. So in conclusion, addressing mental health for children who have been exposed to adversity is multifaceted. We have to think about this from multiple levels of the social ecology, and there are numerous pathways and opportunities for prevention and intervention. Thinking about and mitigating intergenerational effects is an important direction. And when we go upstream, what I hope will demonstrate in some work going forward is that this provides some of the greatest opportunity for impact. So with that, I want to thank the funders of the work, the community partners who I am extremely grateful and humbled to work with, my collaborators, my research team up there on the top right who works so hard and whom without none of this would be possible, and you for your attention today. And with that, I wanted to leave time for questions and to engage in questions. So what I'll do is I'll stop sharing my slides, and certainly questions can be typed in the chat, or people can raise their hands, and I'm happy to take comments or questions.
Thanks so much, Nicole. That was a great overview of your work, and perfect timing with ample opportunity for people to ask questions. So just looking for some hands. Stasha.
Hi, thank you so much for a wonderful talk, and congratulations on your research program. It's really inspiring, right? I just wanted to ask, in terms of the interventions for support, one of the challenges I think is sustainability. Like sometimes we intervene for a short period of time, like for that sort of period of time with our interventions, and then there isn't sort of the long-term continuity. Is there a place for sort of longer term sustained support within the programs that you're developing? And then I was just also wondering about more systems change interventions as system change interventions as well.
Yeah, thank you, Stasha. Those are both really great questions. In terms of the sustainability question, some of the community partners who I've worked with, there's actually variability in that. So for example, the Breaking the Cycle intervention that we're evaluating, they see children from 0 to 6, and most families engage for about 2 years. But many families actually first engage in pregnancy and may stay up until their child's 6th birthday. Of course, what the intervention looks like can change over time, and it's progressive, right? Initially way more focused on relapse prevention because the parents are substance involved, moving up to interventions that focus on the parent-child relationship. So that's an example of one it's funded to do that for families who really, they need the Cadillac, they need the Cadillac intervention. They don't need, a motorcycle or moped or whatever. And so, but I think, how we also operate in a system that has limited resources, where we can't, we can't actually provide long-term and unlimited. But I think maybe how we think about maybe how families are navigated through systems, how they transition from one service to another, or maybe having points of contact that remain consistent and are supportive over time, I think is worthwhile thinking about. In terms of your question about system change, and I'm not sure if you're referring to like broader systems or even within our mental health care system, I think they're things that are important to think about and definitely require the partnership and collaborative piece. Because even in some of the work that we're doing, we can partner with agencies or community organizations or mental health programs that are providing the programs themselves, and provide research and evaluation related to that. But most of the funding bodies that fund at least my work aren't funding, interventions themselves. And so, yeah, I think we do need a reworking, I think, of how we balance and where we invest funds, and I think that's a super important next direction.
Thank you very much.
Thanks for that question, Stasha. And Andrea.
Hi, Nicole. That was such a great presentation. Thank you so much for presenting all your really important work. My question is pretty broad. I was just wondering about the applicability of your research, particularly the last piece on the maltreatment aspect to First Nations, Métis, and Inuit, and your kind of approach to involving those groups, especially because they're so overrepresented when we're looking across Canada, across different geographies, and even the urban First Nations populations and in the content that you're describing.
Yeah, thanks so much for that question. And certainly especially in our sample in Alberta, there was a high representation of First Nation, Inuit and Métis families. And as you mentioned, right, within child welfare, largely overrepresented. And so we, in some of our work, especially now where we're engaging youth in identifying some of the priorities, we have a really strong mandate and mission to ensure that those voices are part of what gets established in terms of research priorities going forward. Several of the sites that we're engaging in our Breaking the Cycle project, with whom we're doing implementation of this early intervention program, are Indigenous communities. And so the humble relational approach that we need to have in bringing in their perspectives, ideas, and also how that might shift and change, and that we don't have a model that fits for all, and definitely needs to be adapted, is at the forefront of our minds for sure. And I actually think there's so much to be learned from Indigenous communities about how we go about doing good early intervention, and about how we have good parent-child relationships.
Thanks, Andrea, for that question. And then Sarah, I see you put a question in the chat, but now you have your hand up. So I don't know if you want to read that question or reframe that question.
Sure. Thanks so much, Nicole. That was a fantastic talk to really orient us to your work. I'm wondering if you could comment on the lack of a child advocacy center in Ottawa, how that would impact service delivery and your research, and what maybe needs to happen for us to move forward in that domain.
Yeah, and so I think, and I'm not entirely sure, Sarah, on like the background details, because I think at one point there was something in development, and then in partnership with another program, and I'm not entirely sure where that is at. But I think that is a gap, and it's often the development of the child advocacy centers they can be driven in a lot of different ways. So sometimes there can be, advocacy groups who really want it to happen, or partnerships that come together between organizations. Certainly, it's interesting because there's one in Cornwall, there's one in Carleton Place, there's one, on the peripheries of Ottawa. There are child advocacy centers, and so I think it's about it is bringing these organizations together, because the advocacy center model itself, they're not providing services, they're coordinating all of them together. But it certainly is really important, because I think increasing research is demonstrating that the coordination of all these services together is actually what's super helpful for families, so that they're not bounced around between systems, having to repeat their stories over and over, and can expedite children's road to healing.
Nicole, I had a question. Given your, close collaborations, ongoing collaborations with Suzanne in Calgary and the team there, and the recently awarded One Child, Every Child large initiative from the federal government, of which Calgary is the lead site, but really it's fanning out across the country. Is there an opportunity to leverage those funds around a child advocacy piece? Because part of the cornerstone of that project is to, in recognition of Canada's poor rankings in child health and trying to move us up the scale. So I wonder if you could comment on that.
Yeah, I think that's a great question, and I think certainly something to consider. One thing that's great about the cohort research is certainly has been well funded, and I really hope actually will continue to be an intergenerational study that can be followed over time. But yeah, I think thanks for mentioning that funding, Jason, and how that might actually be able to be leveraged also in partnership here, and how we can bring that forward. So I think that is a great idea, and I'm really glad that you mentioned it.
Maybe you and I can, offline, we can go back to Suzanne and Susa Bensler, who's the PI, and look at opportunities to, as they're starting to think about how they're going to allocate those funds. Last question to Toby.
Thanks so much, Nicole, for this amazing and inspiring work. And, I love your Desmond Tutu quote. As somebody who is firmly placed in the pulling people out downstream faster than watching them jump in upstream, or at least that's how I feel sometimes. What have you found with, I was quite intrigued by the COPE piece. What have you found in terms of, for the highest vulnerable populations, utilization for online tools? Because one of the things that I struggle with a lot practically is that the populations I'm working with don't read well, or don't necessarily have reliable access to online for financial reasons, or English is not the first language, so they may read and write, but they don't read and write in English. And certainly I would say there's a very prominent disproportion of sort of learning disability, specific reading disability in the parental population for low-income Canadians. And so I've had limited success with sending people to a variety of online resources, and I think the barrier is that's a deterrent for them. So any thoughts on anything you've seen in your work in terms of how people are accessing and kind of addressing that inequity for online access for families for whom that may be a barrier?
Yeah, and thanks for that, Toby. That's such an important question. And interestingly, the Breaking the Cycle program I was talking about, they say we offer nothing online. Everything is in person. Because of the nature of the population that they see. But with regards to the COPE project, so we're in the process of evaluating and implementing that project. So some of it is to be determined. But what we do know is many of the things that you're saying are true with the online interventions, and we're tracking that. So say families who have had a discussion about going to the portal and then maybe sign up and get there and then are like, oh, they might not engage in it. I will say both Make the Connection and COPE it's all videos almost entirely. And it has been designed they're short videos. So it's like you're on social media, but you're actually accessing evidence-based content. And even as someone who myself, in working with the web designers and things, sometimes I'm like, really? Is this how we're going to present this? But I'm old school. I like my little drop down menu. I don't want the burger and all these things coming forward. And for there to actually, be content that's brief. But I think the brief content, it being mostly visual and mostly video in nature, not a lot of reading, and condensing of materials that previously have been, this is not complete an hour, they're 15 minutes. And there's a lot of, notifications and nudging around completing it. And so these are all important implementation questions. And of course, with any kind of intervention, knowing for whom, when, and in what context something works, and that we don't anticipate it necessarily being a one model fits all. But if there are some individuals who can benefit from this that may be, low cost and they can do in the background, then, we hope that it can be helpful.
Great. Well, thanks very much for that question, Toby. A huge thanks again to Nicole for a wonderful grand rounds to close out the year. There is a link in the chat for the evaluation of grand rounds, and have a wonderful summer, everyone, and we'll see you back for grand rounds in September. Thanks very much.